Hello everyone, this is Nirmiti Birud, second MBBS student. Today we will be discussing about antimicrobial drugs. Choice of an antimicrobial agent. Patient factor. Age. Conjugation and excretion of chloramphenicol is insufficient in newborn. Larger doses produces grey baby syndrome. Sulfonamides displace bilirubin from protein binding sites and can cause kernicterus in neonate because their blood-brain barrier is more permeable. The plasma half-life of aminoglycosides is prolonged in elderly and they are more prone to develop eighth nerve toxicity. Renal and hepatic dysfunction. Low safety margin and the organ of its disposal is defective. Local factor. Presence of pus and secretions decrease the efficacy of most AMAs, especially sulfonamides and aminoglycosides. Penicillin and erythromycin for group A streptococci has shown antagonism. If the organism has low sensitivity to the cidal drug, synergism may be seen. Penicillin and sulfonamide for actinomycetes, streptomycin plus chloramphenicol for pneumonic infections, rifampin and dapsone in leprosy, and streptomycin plus tetracycline for brucellosis. To prevent the emergence of resistance. Principle of using two or more AMAs together is valid primarily for chronic infections needing prolonged therapy. To broaden the spectrum of antimicrobial action. Treatment of mixed infection. Two or more AMAs have to be used to cover the pathogens. Clindamycin or metronidazole are generally included to cover anaerobes. However, it may sometimes be possible to find a single agent effective against all the causative organisms. Initial treatment of severe infection. For empirical therapy, since bacterial diagnosis is not known, drugs covering gram-positive and gram-negative bacteria, example penicillin and gentamicin, cephalosporin or erythromycin, and aminoglycoside, metronidazole or clindamycin. Tropically, AMAs which are not used systemically are poorly absorbed from the local site and cover a broad range of gram-positive and gram-negative bacteria and are combined for tropical application. Example bacitracin, neomycin and polymyxin B. Route of administration. Many AMAs can be given orally as well as parenterally, but aminoglycosides, penicillin G, tetracycline, and many cephalosporins such as vancomycin, etc., have to be given by injection only. Evidence of clinical efficacy. Based on the comparatively clinical trials and cost, it is less expensive drugs. Combined use of antimicrobials to achieve synergism, which adds supra-additive effect, additive action. Indifference or antagonism may be observed when two AMAs belonging to different classes are used together. MIC of each AMA is reduced to 25% or less. The pair is considered synergistic. 25 to 50% of each considered additive or more than 50% of each individual antagonism. Two bacteriostatic agents are often additive, rarely synergistic, that is, combination of tetracycline, chloramphenicol, erythromycin, etc. A sulfonamide used with trimethoprim is special case when supra-additive effect is obtained because of sequential block in folate metabolism of certain bacteria. Two bactericidal drugs are frequently additive and sometimes synergistic. Penicillin or ampicillin, streptomycin or gentamicin, vancomycin plus gentamicin for enterococcal SAPE. Carcillin gentamicin for pseudomonas infection, especially in neutropenic patients. Ceftazidime, ciprofloxacin for pseudomonas infected orthopedic prosthesis. Rifampin isoniazide for tuberculosis. Combination of bactericidal and bacteriostatic drug may be synergistic or antagonist depending upon the organism. The organism is highly sensitive to the cidal drug response to be combination is equal to the static drug given alone. Penicillin, tetracycline, chloramphenicol or pneumococci which are highly sensitive to penicillin. Drug factors. Spectrum of activity. Definitive therapy, a long spectrum drug is generally more effective than a broad spectrum drug. Type of activity. Several acute infections resolve faster with the cidal than a static drug. because the cidal drug directly reduces the number of bacteria at the site of infection, while the static drugs only prevents the increase in their number. While bacteriostatic AMAs, the bacteria start multiplying quickly when the drug level falls below MIC. A bactericidal antibiotic is clearly superior to bacteriostatic one in treating the patient with impaired host defense. Relative toxicity. A less toxic antibiotic is preferred. Pharmacokinetic profile. For many organisms, aminoglycosides, fluoroquinolones, metronidazole produce concentration dependent killing. That is, inhibitory effect depends on the ratio of peak concentration to the MIC. The same daily dose of gentamicin produces better action when given as a single dose than if it is divided into 2 to 3 portions. On the other hand, beta lactams, glycopeptides, and macrolides produce time dependent killing. That is, antimicrobial action depends on the length of the time that concentration remains above the MIC. Division of daily dose improves the effect. A drug which penetrates better and attains higher concentration at the site of infection is likely to be more effective. The fluoroquinolones have good excellent tissue penetration. Ciprofloxacin and rifampin have very good intracellular penetration. Choice to be based on bacteriological or diagnostic examination. Bronchopneumonia, emphysema, meningitis, osteomyelitis, urinary tract infections, wound infections, etc. In these situations, an AMI should be selected on the basis of culture and sensitivity test or other suitable diagnostic tests. Bacteriological or diagnostic services are not available. Empirical therapy to cover all likely organisms with a broad spectrum drug like fluoroquinolone, tetracycline, or a combination such as gentamicin and cephalosporin are used. Bacteriological diagnostic services are as in able, but treatment cannot be delayed. Bacteriological services are available and treatment can be delayed for a few days. Minimum inhibitory concentration, the lowest concentration of an antibiotic which prevent the visible growth of the bacteria after 24 hours of incubation. Minimum bactericidal concentration. Presence of necrotic material of foreign body including catheters, implants or prosthesis makes eradication of infection practically impossible. Hematomas foster bacterial growth and lowering of pH at the site of infection. Anaerobic environment in the center of an abscess impairs the bacterial transport process and penetration barriers. Early drug exposure. History of previous AMA has caused allergic reaction. It has to be exposure to an AMA should be obtained and avoided in the patient. Example, drug choice of syphilis in the patient allergic to penicillin is tetracycline. Impaired host defense. Pyogenic infection occurs radially in neutropenic patients, while if cell-mediated immunity is impaired in an individual or non-immunity is impaired, example AIDS, host defense bacteriostatic AMA may achieve cure, while intensive therapy with cidal drugs is imperative in those with impaired host defense. Pregnancy. All AMAs should be avoided in the pregnant woman because of risk of the fetus. Tetracyclines are clearly contraindicated and aminoglycosides can cause the fetal ear damage. Pregnant women are at risk because tetracyclines are clearly contraindicated and aminoglycosides can cause ear damage in fetus. Genetic factors. Primaquine, nitrofurantoin, sulfonamides, chloramphenicol and fluoroquinolones carries the risk of producing hemolysis in G6PD deficient patient. That's it for today. Thank you.